Thank you so much, Ian, and welcome back from lunch. I hope that you had a wonderful meal and you are enjoying some desserts or coffee right now, coffee for sure. We have a wonderful panel planned for this after lunch hour, and I'm going to briefly introduce them. And then we will have an opportunity to have a discussion about this topic, which is to focus, and I apologize, I'm going to go back on the slides if I can. Perhaps not. This topic that is focusing on lowering barriers to care through community engagement. So you will hear 3 talks about this topic. But after this session, we will have a brief break. And please don't forget that we have breakout sessions where you can meet with the previous panel, this panel, and 2 more different groups who will be addressing different issues. So hopefully you will come to one of those and you will be able to get into more in-depth discussion with us if you come to our panel, which will be in the Legacy Room. So very soon we will meet at the Legacy Room. So again, as I mentioned, my name is Borsika Rabin. I am an implementation scientist. I am also the co-director for our Implementation Science Hub at the San Diego CFAR. I'm co-directing the hub with Dr. Nicole Stadnik. And we have a number of members from this hub here today, and please try to meet with them. We would love to meet you. This is my first time at an EHE meetings. It's very exciting for me, and it has a wonderful vibe. So thank you for being so supportive, and having such wonderful diverse group here is really encouraging and invigorating to me. So I am going to introduce briefly our speakers. I am not going to read their bio. Please pull up your app or look at the program. You have their full bio available. That's where you can learn more about them. But we will have, again, 3 talks. The first one is going to be by Dr. Mariano Kanamori and Dr. Stephen Fallon. And Dr. Mariano Kanamori is the director of the Division of Prevention Science and Community Health at the University of Miami Miller School of Medicine. And Dr. Stephen Fallon is the executive director of Latinos Salud, which is a community-based organization focused on serving Latino, gay men, and other groups highly impacted by HIV in South Florida. So that is going to be our first talk. Then we are going to hear from Dr. Lynn Matthews and Deandra Tuyishime. And Dr. Lynn Matthews is, I have a lot of papers here, Director of Global Infectious Disease Research at the University of Alabama and the School of Medicine there. And Deandra Tuyishime is the Chief Prevention and Outreach Officer for Southern Region 5 Horizons Health Services. And they are providing education and outreach around HIV, STI, and PrEP, and I'm sure we will hear more about that. And then finally, the third talk is going to be led by Jeanette Webb, and Jeanette is the Assistant Manager of Implementation Research at the University of Chicago, and does incredible work in education and promotion, experienced in correctional settings for the past 20 years. So we will hear about work from Jeanette Webb as well. So first I'm going to invite the first speakers, Mariano and Stephen, to come up and present.
It's working. Good afternoon. Buenas tardes, Dr. Fallon.
Buenas tardes, Dr. Kanamori.
Isn't it great to see how the EHE family is growing?
It's absolutely growing, and a lot of it through you.
Oh. We are improvising.
I'm not following the script.
Okay. So we don't have any conflict of interest to report.
Oh, what do you? We're already up to this slide. Excuse me. Hello, folks. Okay. So what I'm going to do is I'm going to touch on some of the comments that were made earlier today. There was a lot of talk about how do we bridge the real world with the research world. Our partnership with Dr. Kanamori began 8 years ago, and like many community-based organizations, when we're approached by a research university, many community-based organizations don't know quite what that means. And do you want to say anything else, or should I go forward with that? Okay. So for those of you, I'm gonna speak as if you don't know this, you may well already. But as we were on a learning curve, perhaps this may save some of you the trouble on your learning curve, either if you're the research university or if you're the potential community partner. The world is seen differently by the potential community partners that you're going to, the community-based organizations, as many of you spoke about at the microphones. And there are several issues that are going to be common denominators. The first one is time. The community-based organizations, the aid service organizations, the community health centers that you work with, they very much deal in the now. They're working with people who are coming in with crises now. And it may seem a simple point, but you as researchers are building something for the future. It's the difference between the urgency and the important. They both matter, but when you go into a community-based organization or an ASO or a community health clinic, they're going to say, what's that? Oh, that's going to be for a research paper that's going to come out in 3 years based on a study that's going to start in 6 months. I don't have a bandwidth to even absorb that. So be aware of their different time perspective. The next one is trust. And this is where Dr. Kanamori had a leg up because he was referred to me by a personal friend. CBOs, ASOs, and community health centers often feel a little bit abused by research universities coming in and saying, we need help with this. I hear that you serve Black transgender women who have children, but I'm doing a study on gay men who do crystal meth. You could make that work, right? Give me my subjects. I need my subjects. That's what's important. Or a different version of not trusting is lip service, lip service, lip service, nice smile, I'm on my way in, can I hang my flyer? And no follow-up, no participation. What I'd suggest is you're actually not going to get what you want if you do that. So Dr. Kanamori, from the start, made clear, I'm not just here to fill some deliverables for a grant that I was late finding a partner to and my timeline is running out. I'm here to build a partnership. Yeah, somebody applaud for that. We're going to start with a small CFAR grant, and then he's going to write an R34, and then he's going to write some R1s, and this guy gets every grant he writes, so I don't know. It's been pretty easy for us. Then another temperamental and mindset difference I'd point out is that in studies, we have blinded studies, which means control. But sometimes that effort to control, again, there's a cultural conflict with the community-based organizations and the community health centers because they're very much about getting stuff done. How can I improvise? How can I help this person in the now, right now? And putting things in little boxes, sometimes you have to enforce that because you need your results for your study to be valid. But at the same time, sometimes you pen yourself in. So I'm going to tell one last quick story, and this is not about Dr. Kanamori's study. But a study we're doing right now with another partner, they came in not explaining why, but they said, we're going to send people to you who are pre-screened for eligibility. By the way, we need hundreds of people to get through this survey and the blood draw and everything else. We're going to send them to you. You are not allowed to recruit. You cannot recruit. We will send them to you. It went about 8 months. We only had about 5 or 7 people who were referred in, and only 2 of them made it in. I mean, it was absolutely ridiculous. And we finally asked them, can we loosen this up? And when they explained, well, we were just concerned because we didn't want you to get lost and maybe your person who recruits them is doing the intervention and that's not right. We have to control it. And we said, we can separate that for you. We can have people recruit separate from the people who do the intervention. And now the number of people we're bringing in has gone up 20 times over, and they're very happy. If they had had that partnership meeting from the start, like Dr. Kanamori does, they would have been able to hit the ground faster. So in closing, I'd say this guy's great, the University of Miami team is great, and we love partnering with them. Give them a hand.
I just want to disclose that Borsika invited him. I didn't invite him to say those things, please. But we have an equal partnership, so now I'm going to talk. So, Dr. Fallon, let's share our journey. So, as you said, in 2017, we started our work. with a CFAR Adelante and with an ROO from NIDA. That was the second FAR for my K99 ROO. And during this, in these research projects, we needed to understand whether it was feasible to implement a social network study to understand previous disparities in the Latinx community. We also studied the accessibility to HIV services by Latinx and the overlap between sexual and drug use networks. And in 2020, we have our first NIMH EHE pilot, and this was finishing HIV. In this pilot study, we studied 4 networks, and we tried to understand how these 4 networks could be used to increase awareness and utilization of Latino salud services, diagnose, treat, and prevent. It was a social and friendship network based on Latino salud social activities, a community radio network implemented in partnership with Radio Adictiva, Parks Network, and a pharmacy network that was a part of the partnership with CVS Health. We also assessed the accessibility of these services by all Latinos living in Miami-Dade County. Our second EHE pilot was funded by NIMH and HRSA, and that was Diversity Prep. And we used photo voice. So the goal of this implementation science pilot project was to understand modifiable factors and the behavior of practitioners and support staff, clients, and stakeholders influencing the adoption and implementation of a culturally tailored prep program for Latinx men implemented by Latino Salud. Here you can see how we adapted the components of this strategy with the ERIC strategies. And we use this information to improve our logic model. Then we needed to understand whether a social network intervention will make sense. And that is why when NIMH funded our first R01, the R01 was Preparados. And this R01 included 3 social networks, a sociocentric friendship network, and sexual and drug use egocentric networks, and 2 more protected risk venue networks. So in this R01, we wanted to determine how social network impact PrEP uptake and adherence among Latinx MSM, including both those who self-identify as gay and those who self-identify as bisexual straight. And now we are implementing our second EHE R01 funded by NIAD. And this is the randomized clinical trial finishing HIV, an implementation effectiveness of finishing HIV. And finishing HIV is an implementation strategy bundle of a social network support component and a one-stop PrEP component to improve PrEP initiation of Latino MSM. Participants are recruited at Latino Salud and CVS Health. They are randomized to 2 arms. In one arm, they receive the Latino Salud one-stop PrEP program called Diversity Safe, and they also receive friendship support. In the other arm, they receive a standard health promotion intervention. We collect information at baseline 6 and 12 months. And Dr. Fallon, do you want to continue?
Oh, this is leading up to that. Yes, I'm thinking so much. By the way, it's wonderful to be back at a conference where we're sharing ideas after having been locked away for so long. I'm thinking about some of the other comments that came in earlier in today about developing the next generation of researchers. And it's also important to develop the next generation of workers in CBOs and ASOs. And those 2 things can relate to one another. We have some staff at Latino Salud who did not go to school to get an MPH, and they never would have thought of themselves as researchers, but they have grown in this project, and they are now very engaged in the research, and it's a mutually beneficial relationship. I'm going to stop talking and share a real treat with you. This is our agency video, and it will show you some of the services we do, and I think all of that passion and all of that spirit that's part of the research projects and part of the programs comes through clearly. I'll give them a little chip here. All of this is made by us. This is our staff with our clients. Our staff filmed it. Our staff did the voiceover, the whole thing. I can sense passion in the room. This will move your hearts. Please enjoy.
It's a new day here at Latino Salud. Inside these doors, there's something special.
a safe space for gay Latinos, for their friends and partners, for the entire LGBT community in South Florida. Inside these doors, we've got your back. In the counties with the highest new HIV rates in the nation, our bilingual, certified, professional staff take the anxiety out of visiting a clinic or getting a test. Inside these doors, we offer health education without judgment, screening that isn't scary, case management that activates, and healthcare without copays. We always make it easier for the community to access services. We take the wait out of waiting rooms. We accept walk-ins and appointments. And we stay open later than any HIV STD agency in Florida, to 9 p.m. nightly. Both in and beyond these doors, we're also offering more free community engaging events than ever before. Our events bring guys together for recreation and connection. They build resilience and confidence. What's it all add up to? Last year, we served more community members than ever before, over 12,000, and we doubled the number of patients we're maintaining on PrEP, the pill that prevents HIV. And we're taking other big steps. We're now providing healthcare for everything from hypertension to hyperlipidemia, from diabetes to hepatitis C. Our ACA health insurance support program pays the monthly premiums for hundreds of our patients in greatest need. And our new health and support service Pride scholarships are closing the gap by developing culturally attuned South Florida professionals in careers such as nursing, psychology, social work, and public health. How do we fit all these programs in? 3 years ago, we tripled our space in Wilton Manors. Last year, we added a new North Miami location. And we're still growing. This year, our new location in Miami Southwest will offer even more counseling rooms, testing rooms, and provider suites, all in a welcoming event space to empower our community. You've always dreamt of a place like this, a place where you can come as you are, get the services you need, and build your best life in good health. You made it to Latino Salud. Welcome home.
Thank you, and I want to finalize this by thanks to our program officials from NIMH, from NIATS for your support, for your belief in our science, to the San Diego Hub, Borsika, Rabin, and Lauren Smith for being such a great mentors. Our lab, they are there, Latino Salud staff, our partners, Susan Blakey Lewis, Donna Spiegelman, and Iski. Dennis Lee, thank you for your support, and JT Smith as well. And as you can see, there are many people behind us, helping us and supporting our projects. But in front of us, there are also many people who are very grateful for the work that we are doing, thanks to the EHE program. Thank you.
Thank you so much, Mariano. Thank you. So I'm going to invite Dr. Lynn Matthews to come and present. And then, of course, your partner is joining as well? Yes. Wonderful. All right. Okay. Deandra is joining as well.
Great. So we were already introduced, and I'm going to present here with my colleague Deandra Tuyashime on behalf of our team, Mobile Testing to Increase HIV Testing Uptake in Rural Alabama. We call this project Mobilize. We do not have disclosures. And actually, Commander Sandoval Rosario already covered this. So I'll just highlight, I'll do a little, sometimes a geography lesson is in order. Oh no, the mouse doesn't actually show. Okay. We're coming to you from Alabama, which is one of 7 EHE-focused states based on the rural epidemic. Alabama is the state that is north of Florida. Maybe everyone knows where Florida is. Alabama is sometimes people don't know where it is. So we are a focus state because of the nature of our rural dispersed epidemic. I've been working with colleagues at University of Alabama and at Five Horizons and other partners for a couple of years now, trying to think about how do we close some of the HIV testing gaps in our context. CDC data suggests that about 37% of people in Alabama have ever tested for HIV, and that number is lower in our more rural communities. This is a slide summarizing too much data, but just to take you through again without a pointer, which is unfortunate. Do we really not have any pointer options? That's okay. I'll get over it. On your left, we used commercial testing data to get a sense of HIV testing coverage per unit population. So the lighter areas are zip codes where the testing coverage was really quite low. And on the right, you can see what we did. We used modeling data based on baseline CD4 count diagnosis using EHAR's data. And the darker counties have a longer time to diagnosis. The county with the longest time to diagnosis on this map is Wilcox County at 12 years, median time to diagnosis. So we look at that and we think about, okay, we want to target area, we want to reach areas where there's low testing coverage and either overlie next to or within high prevalence counties or next to or within areas with a long time to diagnosis. That might help us get people who haven't yet been reached by testing. And how do we do that? If you know the state, you know that some of these areas that are lighter are really far from maybe where we're based in Montgomery and Birmingham. Many of the challenges that people in rural America face accessing testing do overlap with some of the challenges that have been seen in global settings where HIV is more endemic. Gaps in accessing transportation, concerns about provider discrimination and stigma around HIV, financial constraints. We already talked about Medicaid non-expansion states were another one. Sparse overtaxed clinics and confidentiality concerns where the person who may be testing you for HIV might be someone you're going to see at church on the weekend. Mobile HIV counseling and testing has been shown to increase testing coverage in a lot of settings. The WHO recently did a meta-analysis that shows that this is a great way to increase testing uptake, diagnose people earlier with a trend towards reducing HIV incidence. Makes sense. You can increase testing availability, maybe reduce some of the stigma associated with accessing certain facilities, reach hotspots, but not much is known about how this might work in a more rural American setting. We've together had 2 different EHE supplements through the UAB CFAR to think about mobile testing to increase HIV testing uptake in Alabama. Deandra comes from Five Horizons Health Services. She's in the southern region, so they're based in Montgomery, and their service area includes all of those counties colored in red. It's a vast area, and they do a lot of work. Our pre-implementation work was doing key stakeholder interviews to think about where would we go and how would we refine the messages, and then afterwards we did some evaluation of the implementation of mobile-based counseling and testing. Our pre-implementation findings we've already published, but what we found from our key stakeholders who talked to us was that if we were going to do non-facility-based out-of-clinic testing, it would be important to have opportunities to link clients to rapid treatment and PrEP. It would be important to have methods for refining for addressing stigma. And this was a back and forth this morning in the first session. Our key stakeholders told us integrate HIV testing with other screenings. Don't just say you're here for HIV. That is not going to work. And then, of course, integrate with community champions as you try to get into new communities and contexts. You're going to have to work with the people who are already known and already working in those areas. So I'll turn it over to Deandra for our methods.
So as a community-based organization, how were we able to implement this study? Our population and setting consisted of adolescents and adults ranging from 18 years to 65, those living in Alabama, obviously, particularly in rural counties called the Black Belt region that you can see there on the map. And recruitment took place in our clinical setting at Five Horizons, but also at college and university campuses, health fairs, job resource centers, substance use support centers, churches also, and also through our recruitment flyer that featured a QR code that allowed easy access to the survey. So the survey itself included questions regarding demographics, HIV, current HIV status, perceived HIV risk, prior, future use of HIV testing or home test kits, acceptability, feasibility, appropriateness of mobile-based testing, stigma, barriers to health care, medical mistrust, and social support. Some of the challenges and adjustments that we faced during this, including delays in deployment, procurement procedures, personnel protocols, and I'll get into a little bit of that later if we have time. Leadership challenges and challenges at our partner site, community buy-in during this major transition that took place. We shifted strategies to explore experiences of other forms of outreach and testing that occur outside of the clinic, and the length of the survey was difficult for some people to commit to in the time in ways that we could make that a little more brief. Apologies. So we recruited 181 clients to participate with a mean age of 37 years. Most participants were women and identified as Black or African American. Risk perception was low for most. HIV stigma, barriers to care, medical mistrust, and scores were medical mistrust scores were mid-range. Social support was 66 on a 0 to 100 scale. The map that you see shows our reach across 18 counties in Alabama. That was widespread, which was a bit surprising for us and also good. All 181 participants had experience with HIV testing. However, only 22% had ever accessed mobile-based testing, HIV testing, and counseling. People with more social support and higher perceived HIV risk and more barriers to care were reported to be less likely to see these services as favorable. So the overall interest in HIV self-testing. And we explored HIV self-testing as this is a perfect opportunity to increase through mobile-based HIV testing. A little over half of all our participants had heard of HIV self-testing. About a third had utilized HIV self-testing. Fewer than half of those participants were interested in HIV self-testing, and just over half were interested in distributing HIV self-testing to their community, partners, friends, and family. Our model suggested that those with higher perceived HIV risk, they were actually less likely to be interested in HIV self-testing. For those who did not pursue HIV self-testing, the most common reason was that they would have liked to be with a counselor while it was taking place instead of by themselves. So in summary, clients across Alabama are indeed interested in non-facility-based testing. HIV testing is an option for many, but it needs to be coupled with a direct link to counseling and follow-up care. Most survey participants were women, which is awesome because women are often left out of prevention, HIV prevention conversations and programming, but also speaks to a need for creative ways to reach men using mobile testing, and especially Black men. The implementation of mobile testing requires clear protocol and procedures to obtain, maintain, secure, staff, and manage the unit itself. Resiliency, creativity of our community-based organizations and leadership in Alabama is needed with the overall passion for the work itself. Subsequent activities. So here, I think I have a little time, maybe, to speak on some of those things. So I mentioned some of the transition. The former organization, which was named MAO at the time, dissolved unexpectedly. Staff were laid off. So many things happened. And Five Horizons was able to pick up care of all of those counties, also branching off into Tuscaloosa, West Alabama, and over into Starkville, Mississippi. So we have a wide stretch, we have a big reach. But in that time, there was community distrust. Some people were out of care. How do we build that trust? So the one MGM project work is focused on Montgomery and surrounding areas to rebuild trust partnerships, and we use the mobile testing unit or the mobile van to show up, just to show up. Where are people? We showed up to say, hey, we are still here. Are you out of care? Come back. And in new spaces to offer the survey to get feedback on that. Also, we were able to reach broader populations, like I said, showing up wherever people were, people experiencing homelessness, the local libraries, creating partnership, open mic nights, football games at HBCUs. We were there, we are there. And also planning for maintenance and upkeep of the van, upgrading the mobile testing unit to include bathroom facilities, to to ensure that we have better services, and also especially important for integrating STI testing within the community is something that we're working on to reach far more people, especially in rural spaces.
Some of our other subsequent activities, one of the, we are fortunate to be funded through one of the EHE RO1s, me together with my MPI, Dr. Adi Arana. And with this project, we're doing a couple of different evidence-based interventions with partners in the Mobile County Health Department, which is down on the southern coast of Alabama. And one of those interventions is data-informed testing outreach to expand their testing reach as well. And we're really leaning on everything that we learned from our partners at Five Horizons to inform that. And in fact, later this week on Friday, we're having a roundtable in Montgomery hosted by Deandra and her team to work with different community-based organizations across the state who are all kind of dipping toes into mobile-based testing to think about what can we learn from each other. Because what we learned from this project is that it is like a lot harder than it sounds like it's going to be. And everyone's doing it, not everyone's doing it, but a lot of folks are doing this. And so we're coming together to think about how do we do our best. And I'll end by thanking the UAB CFAR and our co-investigators and our community partners, and end there. Thank you all.
And then we have one more presentation. These are wonderful. Of course, Jeanette Webb is going to talk to us about engagement to support the health and service needed of criminal legal involved populations in Illinois. Thank you so much, Jeanette.
All right, good afternoon, everyone. I know that sugar, the cheesecake got you, and the salad is weighing on you, and the steak, those of you that ate the steak, let's try it again. Good afternoon. Okay. So you see the title right there. I won't belabor that. However, I will say a little bit more. I've had the opportunity to work at Cook County Department of Corrections in a specific position with healthcare, and from that grew my opportunity to be able to grow into the area of research with the knowledge that I've had working in corrections, which is a wonderful partnership. It's a sad partnership, but it is needed. Does everyone feel me? It is needed, okay? So I want to say thank you to Dr. John Snyder, Dr. Russell Brewer, Dr. Chad Zaywitz, who is the medical doctor who is also one of the PIs for many of the jail projects that we have done, and then also Dr. Mayenza Durrell, who is the Director of Research for the agency that I represent. Let me tell you a little bit about the agency. It's known as The Village. It is an LGBTQ-friendly, safe space, a supportive environment. That is the nickname for it. Our center is specifically the Chicago Center for HIV Elimination, and our entire CCHE team works tirelessly in order to reach out to the community, but we are still learning and growing because the relationships that you have to build, that's liquid, because environments change, times change, finances change, just life. We all know that in here, right? Okay, so some of our partners are here today, and I want to say hello and thank you. Dr. Nina is somewhere around, and also Julie waved at me as well, too, so I want to say thank you to them. They're just some of our partners that we've worked with. So, okay, there we go. So the presentation outline, the rationale is to focus on criminal legal involved populations, provide examples of how we are engaging such populations, to also provide an overview of some of our center efforts, to share some of the results of the EHE funded program. Specifically, the one I'm going to talk a little bit about today deals with a PrEP implementation in jails following the release from prospective stakeholders. I'll talk a little bit about that, and then of course some concluding remarks. So the rationale, again, criminal legal involved individuals identified as a priority population in the Getting to Zero in Illinois program. So we know criminal legal involved populations are the most marginalized, limited resources, rapidly failing infrastructures. Just the general infrastructures we're dealing with are failing, but theirs are declining even faster. Lower levels of academic involvement and completion, lower wages, lower opportunities for employment, like I said. So compounded with the situation of criminal and law enforcement histories having been involved, whether it starts from a little bitty thing as child support, traffic tickets and going all the way up to, and I won't say how big it can be because we already know the story, okay? We're looking at pre-detention and detention and post-release incarceration periods that have been identified as the most important opportunities to provide intervention for biomedical and socio-structural interventions while they're there. Captive audience, let's work with them while they're right there. Let's work with them where in a time that they may seem to be the most broken, but that's also a good time to talk to them. Time to talk and listen. Time to establish a relationship, get your name in the ear of one of them who may be a gatekeeper to your communities that you want to get a hold of, and let them know, I'm there for you. I'm not seeing you because you're inmate number blah, 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 and I see beyond the brown or the blue or the neon orange jumpsuits. All of our states have them. We see you beyond that. We know you are a flesh and blood person. You have dreams, you have aspirations. Let's work with the real. So the types of engagement. Multiple client-facing opportunities at the Chicago Center for HIV Elimination. We have a unique opportunity to conduct research, and we utilize that opportunity with research with HIV, with STIs, navigation services. We have a wonderful partnership with a very popular healthcare provider in the LGBTQ community, which is Howard Brown, okay? And they are known for being a wonderful safe space and nurturing environment and providing progressive health care for that challenged and marginalized population as well. So why reinvent the wheel? Let's partner with them and let's see if we can push this a little bit further to reach out to people. We're trying to definitely deal with aspects of consumer engagement. We have definitely CAB boards as well, but we also not just pull them in, but we want to partner with them even longer than just for a study because they obviously were vested enough to want to be a part of what we're talking about, so let's keep it going. Agency networking, of course. You can't come in and say, we need you, can we have your numbers, can we have your people, and then leave. You have to come in and say, can we connect with you? Because this is what we offer you. How can we be of service to you? Develop that, and then see from that point how your research can possibly be a part. Now, we've had a long history with Cook County Jail medical staff, and it also helps to have individuals that are there that have been in the jail system, have worked in the jail system, and know how to navigate through it because corrections is its own language. Corrections is its own environment. And if you've never been in, that's okay. If you had a chance to go in and work there, you understand exactly what I'm saying. But if you don't understand it, even if your project doesn't have anything to do with corrections, I still say take a look because somebody in the family of one of your target groups has gone through that, and that is still affecting that household. Post-COVID engagement. So after COVID, all kind of rules and regulations. What can we do? What can't you do? Oh my gosh, what's going on? Yes, we all had to jump through those hoops. But again, now we look at it, okay, let's look at it further. Can we develop opportunities to build relationships with juvenile justice? I've heard here, prevention, prevention, prevention. Let's catch them at age 12 and 13 before they get to age 32. So in the juvenile level, if we can stop them and catch them before they become that adult offender, why not? Why not? Okay? All right. So, research priorities. Research priorities, of course, the impact of incarceration, how feasible is it? Looking at current PrEP care in the landscape of Cook County Jail, yes, we actually tried to offer PrEP in the jail. Believe it or not, we did try. The first two questions on there focus on the early work of the center. The third and the fourth question that you see on the screen deal with HIV and PrEP landscape in the correctional settings, receiving the EHE funding in order to advance our PrEP care work. Okay, and question number 5 on the screen deals with where are we now? Speaks to our newest project. We do have another project coming out now called J-Rise, and it is dealing with individual status neutral, some with criminal legal involvement, others that are not cisgendered women, men, all gender inclusive. So we are stretching out the opportunity using research to even reach more populations. So here we go. Cook County Jail, this is just one building. This is Division 8. This is one of our intake buildings where people come in and they're screened and then they're housed in this building. This is one of the newer buildings. And then this other one, this is other one building. This is Division 11. Behind Division 11, as you can see, there's a yellow sign that says boot camp. So in that area, those who are low low bond offenders, first time didn't want to send them to the penitentiary, they sent them there in order for them to serve their sentence where their families could still have a connection with them, because otherwise all of the prisons are pretty much way far out, and it's hard for families to go and visit and keep that connection with mom, with dad, with uncle, with cousin, whoever. So they came up with this concept. That is just Division 11. So you need to know Cook County Jail is the largest single site facility in the country, estimating a population of almost 6,000. It could be up as high as 12,000. They're going through some construction at this time, but it is a huge facility, huge. And I have been there at points when it was packed to capacity. They were being fined for people being on the floor, all those kinds of things, because, you know, so that goes with the partnership with law enforcement. Watching my time. Okay, prep. Okay, don't want them to turn the music on me. Okay, so so in talking about conventional oral PrEP provided at Cook County Jail, post-release, injectable PrEP was unfortunately not offered, but is it needed? Yes. Do we need to have that conversation? We're going to. So 3 main opportunities for PrEP access in the jail. Individuals who are currently taking it can request it upon entry. Individuals who are eligible can bring it up during a clinical encounter. How about that? The provider can introduce it. How about that? One of the champions in the jail can be trained and actually provide that information to a person. Well, here's the thing. We got to get those champions to stand up and be champions. Some of them feel like, oh, it's another thing I have to monitor, watch, and look out for, and it's not officially life-sustaining. I don't get paid enough for that. I'm sorry, we're dealing with a human life here. We need to offer them services, offer them ways to, what's that key word again? Prevention, true prevention. Let's not let them get sick, so we have to go the U equals U, even though that's great. Let's keep them healthy, so then therefore they can spread the word about how not to get it, and then also be a model of this medication and this program can work. Okay? One of the things we also do is notification is sent to the provider 24 hours before a person is released. Inmate here, pretrial detainee, getting ready to release to the community. Cook County Jail is connected with Cook County Health and Hospital Systems, and that is connected to the overall outside county network of medical services. So when they're released, the prescription goes to typically Stroger Hospital, and so a person can get an additional 30 days of an e-prescription of PrEP to continue until they connect with a healthcare provider. That's good for continuity, isn't it? Okay. So let's look. 20 providers could potentially prescribe. The biggest barrier is getting that buy-in. It's a training issue. It's a comfortability issue. It's a generational issue. Providers that have their own bias based off of when they came up, et cetera, et cetera. That kind of blocks giving care. That shouldn't, but it does, because we're human. So we need to provide them with additional training and support to help them beyond that, so then therefore they can see the person for who they are and not based off of what I have come from. Not my religion, not my culture, but my responsibility to you as a provider. Buy-in. We need education to be repetitive and reminders for the stakeholders. Please, 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 let's try to do this. Let's try to do this. Okay, we can take lessons. Whoops. I'll just do that. We can take lessons from the Narcan. We had a wonderful Narcan educational effort going on in the jail. Everybody knew that they could ask for Narcan. They knew they could ask for Narcan. But we want them to be able to feel that way about the PrEP. And then long-acting PrEP injectable can help to eliminate the stigma. And the perceived barrier to long-acting PrEP is, there is a cost, but there is a window of opportunity while they're working there. But here's part of the problem. Even though we're in the jail dealing with a marginalized population, we're not getting any discounts. We don't get any cost cut or anything, and they know this is the area that needs it. Why won't you do that? Pharmacology, that whole, okay. So there we go. In conclusion, oral PrEP and e-PrEP prescriptions are currently offered at the jail. Injectable PrEP is currently not provided. We have strategies that are trying to build buy-in from the stakeholders in the community, as well as the champions that are in the jail. Injectable PrEP may alleviate some of the PrEP stigma. And then with short jail stays, there is an added challenge of providing the 2 additional injections that are needed, the 1 month apart, for their care. So those are things that need to be figured out. And thank you so much for your time.
Okay, this was wonderful, very meaningful, very inspirational, and entertaining from all three groups of speakers. Thank you so much for doing this. We have about 15 minutes. Is that true? 10, okay, different a little bit. So viewers, we have 10 minutes, and I am going to open it up for questions from the group, so please feel free to come up to ask questions. But I will say just a couple of things while we have people come up. One thing that I heard across all three presentations is that the paradigm that we have been using in research, that if we build it, they will come, and in other areas that never works, is actually really falsified here, because everyone talked about how if we go where they are, they will participate. And I just love the different creative ways that you came up with, engaging with the communities in a way that it was meaningful to the community, accounting for the contextual dynamic nature, that the context changes over time, that instead of fighting against the reality, the context, using rigid designs and thinking about timelines that work for funding, work for research, you were all thinking about what is the timeline for the community, what are the contextual opportunities, and not so much barriers, but opportunities, building on existing networks, building on situations where, you know, if they are here, let's take advantage of it and engage them. And also just using strategies that the partners, the community members can relate to. And this is just wonderful to see that that is the norm in research now. And I look forward to, and there are ways to still rigorously validate, rigorously evaluate this work. We don't need to use always the same design. We have to match the designs to the research questions, and all these presentations showed how to do that. So thank you so much. You give me hope and again, inspiration. And with that, I'm going to open it up for our first question.
Thank you. Am I on? Yes. Thank you so much for what a great panel, the perfect panel to have after lunch when we're all starting to slump. So much innovation and passion and excitement. You're all fabulous, but I'm a Chicagoan, so my question is going to go to Jeanette and the great work that you are doing. I'm just really, really curious as a longtime policy and advocacy person trying to get condoms into prisons and jails and facilities and seeing people's heads spin around like The Exorcist when you bring it up. How are we able to get PrEP into facilities when, quote, sex is not allowed and we have not been able to get condoms? Most facilities in the country can't get condoms. So how have you all gotten PrEP behind the walls?
Okay. Hello? I'm good? Okay. I was not a part of the conversation when that took place, but I can tell you from my earlier background in being a public health educator at the jail, and I started working at the jail in 1991. I'll embrace it. I'll embrace it. 1991, I was completely green. Green is that exit sign back there. Coming from college and all the things that they tell you in school, you know, it's not the same thing once you get inside the building, actually working with people. We had to fight in order to just get HIV testing. We had to fight just to be able to provide information. And then we had to fight to be able to have condoms in the building. The condoms were able to be given to the correctional officers, but we couldn't give them to the pretrial detainees. I don't use the term inmate because that's not what they are. They're pretrial detainees, innocent until proven guilty. So we had to come up with ways in order to get them in there. So, okay, the superintendents would say, fine, give it to the officers. And if the officers happened to give it to individuals, we turned our head and said, here's some more. But officially and legally, we couldn't. You're absolutely right. How PrEP came into, it was because of a research study in order to be able to offer it. And so this PrEP intervention was offered in relationship to a study, okay? And that opened the door up for other opportunities for that to be able to continue. At any given time, there could be 12 people that are on PrEP at the jail. We're trying to get more buy-in to it because that definitely affects the overall community once people leave. Well, bravo. Thank you.
Good afternoon. I'm Katrina McCoy. I'm a researcher at UNC Charlotte. I'm affiliated with UNC Chapel Hill and a EHE recipient. I'm also affiliated with the UC San Diego Hub. So as we build these partnerships, and as you all see, we built partnerships from San Diego to Charlotte and beyond, and we think about the partnerships that we build with our local jurisdictional areas, as we think and try to plan and be inclusive in that planning process from the initiation of ideas, one thing that I haven't seen is including our community partners in the, and it came up a little bit earlier, the budgeting piece. We go and we say, hey, we have an idea. This is before we've actually brought them to the table. So the allocation of funds have been made. So I'd like to ask, what strategies are you all using to engage those community partners from the initiation, even at the point when the budget is being made? How do you not necessarily compensate, but compensate them for their time and effort to help with recruitment and all the other things that we rely on them so heavily for?
So very good question, thank you. Let's thank for that. We have 3 minutes, so this is going to be starting conversation. We are going to continue it in our breakout. So let's have 1 or 2 answers, and then when we finish here, we will move over to our breakout session soon. So please.
We use community-based participatory research, and to have a true community-based participatory research takes like 7, 8 years. You cannot have that partnership in 1 year. Sure. But I think that what is important is to respect the community, is to have an equal relationship, and there was a point in the relationship between the community and the and academia when we actually speak the same language, when we design the project together, and when we develop the budget together. You know, sometimes I develop the budget and Dr. Fallon said, no, Mariano, I'm sorry, but I cannot work with this budget. You need to allocate more budget to Latino Salud. And that's it. In some of the R1s, the budget is even higher for Latino Salud than for So I think it's a relationship, and the relationship gets mature, and then you trust, and then you work together.
I think also, I would say that with our projects, we engage with them at building, as soon as we're building the budgets. But I think an important thing to comment on here in this group is that Deandra talked about how the organization she had been leading outreach with dissolved, and we had a supplement. We had 2 supplements active at the time, and we knew we were pretty sure they were going to come back, and there was going to be an opportunity to still do the work. And the leaders at the community-based organization, as things were evolving, really wanted to do the work. But in the meantime, like, we weren't spending. So then when our CFAR got more money, they got all of the money that was supposed to be being spent on this supplement and a whole bunch of other ones. And so it actually was fiscally very complicated when that kind of thing happens, because the CFAR still needed an operating budget, but the money that was being held to do this work because we all really wanted to do it was sort of taken away. So it's so many levels of complexity. Yeah.
So I would say, just so that we don't run out of time, that we close on this note and continue again. This discussion could be one of the topics that we bring up in the breakout session. There will be 4 different breakout sessions starting in about 15 minutes. I'm not trusting the, okay, very good. And so you will find on your agenda the location for those sessions. So Legacy will be our session, but there are 3 others. I think these are now listed here. Please join those, and there is a little bit of a break, but I will hand it over to Uyen, who can provide a much more meaningful transition. I just wanted to thank the panel for the amazing, really great after-lunch presentations, and thank you for everyone.